Welcome to the AMA Steps Forward webinar series. Before we begin, a few housekeeping items as usual. This session will be recorded and available after the event. And if you have any questions during the presentation, please place them in the Q&A. We will have time at the end of the presentation to answer many, if not all, of the questions. And if any other questions arise, please feel free to contact us anytime via the Steps Forward inbox. That's stepsforward@ama-assn.org. All right, let's go ahead and introduce today's speaker. I am so thrilled to welcome Dr. Angela Chaudhary to speak with us today. She is an associate professor in obstetrics and gynecology at Northwestern University Feinberg School of Medicine. She currently serves as the chief of gynecology and gynecologic surgery at Northwestern Memorial Hospital, managing gynecologic quality, safety, and operations. She also serves as the director of the P2P Network, which is Northwestern Medicine's physician peer support program, helping to support physicians through adverse events, distressful patient situations, and physician burnout. Dr. Chaudhary received her MD from Northeastern Ohio Universities in 2000 and completed her OBGYN training at Washington University in St. Louis in 2004. She then completed a fellowship in minimally invasive gynecologic surgery at Florida Hospital Celebration in 2005 and completed additional training in organizational change and leadership coaching at Northwestern University's School of Education and Social Policy in 2020. Dr. Chaudhary's clinical work focuses on minimally invasive gynecologic surgery with special interest in uterine fibroids, endometriosis, and transgender healthcare. Her research additionally focuses on physician wellness and burnout, surgical coaching and education, simulation education, and leadership skills development in the healthcare space. Today, Dr. Chaudhary will be presenting on physician peer support, an organization's secret weapon to combat physician burnout. So once again, welcome, Dr. Chaudhary. Thank you so much for joining us. It's such a pleasure. I am going to pass over our virtual microphone to you.
Fabulous. Dr. Jen, thank you so much for that amazing introduction. And thank you so much to the AMA Step Forwards team for this invitation to present our work and what we've been doing at Northwestern thus far surrounding the physician peer support space. I hope today all of you have an opportunity to really learn more about what we do at Northwestern, but maybe also how you can take this back to your own organization to really figure out how peer support may work for you. These are my disclosures. So my objectives really for the talk today were to really begin to describe for you some of the organizational drivers of physician burnout and begin to discuss and delineate the utility of peer support for both individual support as well as potentially for culture change in your organization. And I really want to talk about what I think is really necessary from the experience we've had at Northwestern, as well as to discuss some of the potential barriers to peer support in an organization. Now, this is a schematic of a battery. As all of you know, physician burnout has really been described as an epidemic in our country, especially with the recent events of the COVID pandemic. But even prior to that, many people were researching physician burnout and have really described it as a syndrome that encompasses three main qualities: emotional exhaustion, interpersonal disengagement, and a low sense of personal accomplishment. At Northwestern, we use this battery schematic often. In fact, even in our most recent engagement surveys. How are you feeling? Are you in the green? Are you in the red? Are you feeling empty? Are you feeling like you just don't have enough to go on with your jobs? And what can we do as physician well-being advocates to really improve that, to get you back into the green? What programming can we do to get you to a place that you feel like you can come in and be ready to do the job that you love every day? So often when I talk about burnout at Northwestern, I always have the occasional cynical colleague that comes to me and says, why in the world does our organization even care about us? Why do they care about burnout? They don't seem to care about other things. And they're very simple and very frustrated. And this is a great representation for one of Dr. Tate Shanafeld's work, looking at both the personal and professional repercussions of physician burnout. So many of us have heard or seen some of these personal areas: broken relationships, alcohol or substance use, depression, and of course, the concerning epidemic of physician suicide currently in our country. But from the professional standpoint, and what our organization also sees, is that when physicians are burnt out, it's been shown that there's a decrease in the quality of care, as well as an increase in medical errors, which obviously impacts the whole organization, as well as their patients. We also see decreased patient satisfaction. And I don't know how all of your organizations handle patient satisfaction, but this seems to be one of the prime concerns currently at an organizational level and what they sort of test physicians on all the time. We also see decreased productivity and professional effort, as well as probably the most expensive one, physician turnover. With each physician that leaves, organizations lose hundreds of thousands of dollars in recruitment costs and lost patients. Dr. Shanafelt also talks about some of the organizational drivers of burnout. Now, when you ask a colleague, why do you think you're burnt out? Almost always, they'll say things like, it's all this electronic medical record charting. Maybe they'll say, I just don't get paid enough for the work that I do. But actually, what Dr. Shanafelt did was really look at what he describes as the key drivers in an organization that either drive us towards burnout, towards exhaustion or cynicism or inefficacy, versus towards engagement, vigor, dedication, and absorption of material. And really, the EMR nor your money that you make is actually what's here. They talk a lot about control and flexibility, what your work-life integration looks like, what social support and community that you have at your work, what the organizational culture is, and whether that matches what the values of the organization match with your own personal values, what your efficiency and resources are, and that might include some of the EMR work we talk about, as well as what your workload and job demands are. And there in the center, you see meaning in work. And so when I started this work back in 2017, 2018, I surveyed my department of OB/GYN at Northwestern. And what we found was actually we had lower rates of burnout, somewhere around 28%, compared to a national level of over 40% in obstetrics and gynecology. But actually, when I tried to delineate out why people weren't burnt out as much as maybe we saw on a national scale, it all came down to the meaning in their work. Everybody felt like the meaning that they had in their work, the patients that they cared for and the work that they were doing, tipped them back towards engagement and made them want to come to work every day. And I think thinking about that and how we approach physician wellness and physician burnout, we really need to think about all these drivers and how they might individually affect the colleagues that we work with and ourselves. So when we talk about this, everyone says we want to lead into a culture of wellness. This is the goal. We have so many chief medical officers coming to fruition at different hospital systems, and everybody talks about this. We want our healthcare workforce to be well. Well, what does that mean? I'm going to start with telling you what I think it doesn't mean, okay? First, it's definitely not free food in the doctor's lounge. It's definitely not giving us a meditation app for us to do on our own time at home. It's certainly not yoga at lunch, and it's not mandatory naps at work like our residents are now required to get. It's certainly not resiliency workshops or wellness CMEs, because frankly, those are requirements that actually take away from the other things that we might want to be doing with our time. And it's unfortunately not even more money, even though people think if they were getting paid more for the work they were doing, that might really improve their well-being. And it's been shown that that's not really the case. That instead, the ability to have control or flexibility, to feel like you're getting paid what you're worth, all makes a difference in burnout, but actually the alone raises don't actually make a difference. So here at Northwestern, we've really spent some time considering what we think is really important in a culture of wellness. And there's a number of different models of this around the country, but ours really focuses on three main areas: caring for individuals, working to enhance our workplace environment, and finally, building community. And when we talk about peer support, which we're going to get into more detail about, we really believe strongly that we need all of these three things to work in concert to really become, for people to really become well. And our peer support program was initially developed to really care for the individual. And I feel like now it's grown over this last year to year and a half. And what we're finding is that we're changing our communities. We're building more community at our very large organization to try to make it a better place to work. I'm sorry, guys. There we go. So finally, peer support. What does it mean? Well, peer support is really defined as interactions between people with shared similar experiences to begin to create support structures. And when we think about peer support in healthcare, it seems very new. But actually, it's used in organizations all across the country. We see it in addiction for PTSD with first responders, such as healthcare workers. We actually see it in chronic illness. There's a number of diabetes peer support programs out there where peers with diabetes help others with diabetes. We see it with workplace trauma. There's much of this work in the firefighter community and the military community. We see it surrounding anxiety and depression as well as victims of abuse. Probably the most famous peer support program is Alcoholics Anonymous, the 12-step program, where you're assigned a peer supporter, a peer mentor, somebody who can help you through the difficulties that you're experiencing. So when we started this program and we really started to think about what entails peer support, we thought first about peer mentoring, this idea that there's a relationship between people who are at about the same career or age, in which one person may have more experience than the other in a particular domain and can provide support. The other sort of idea behind peer support is peer coaching, a confidential process through which two or more colleagues work together to reflect on current practices. And I do a lot of this work actually as an executive coach to really help some peers deal with transition or change in their workplace. And then finally, emotional support. So when we started our program at Northwestern, what we really found was that we were going to focus on the emotional support. And we were going to start out looking primarily at peer support surrounding adverse events. But what we found is actually we're utilizing the peer mentorship and the peer coaching models as well as we've begun to expand our program, which I'll share with you now. But what really people define from a peer support perspective is that there needs to be a relationship of equality. I told you about the survey that I did of my department when we first started some of these programs. And many people said that they didn't want to seek support because they found that they would always have to go to a psychiatrist or a therapist to get support after an adverse event. And that just didn't feel like what they needed. Instead, with peer support, by going to a colleague, there was a relationship of equality that allowed people to really open up and really be able to sort of talk about what their experiences are and what their feelings were surrounding those events. Much of this work in peer support, as I mentioned, has come from many other areas in different organizations. And actually, this comes from some of our military work. They described this scenario of going from green to red, which I thought very much mirrored our battery analogy I showed you at the beginning of the talk. But really, they talk a lot about that in the ready stage. That means we're ready to go, we're well rested, we're ready for whatever the day is going to bring. If we're in the red, this is where we really shouldn't be working, where we are ill and may really need to actually be removed from the workplace. It's funny though, there's an article called Stress First Aid for Healthcare Workers. And they talk about the fact that we as healthcare workers actually veer between green all the way down to orange and back and forth, even on an everyday basis, on an everyday workplace. And so from what people tell us is that even just having a bad day in the operating room might put you into the yellow. If you have a really severe complication, you might be living orange and you're still operating, you're still working. And how do we work to get you back up to the green? And this is one of the areas that I think peer support can be so beneficial. So this is a quote from Don Berwick, who's a former administrator for the CMS. And he really describes that healthcare workers who get wrapped up in error and injury, as unfortunately we know we all do, that really we are actually victimized by some of the events that we had, that this is an occupational hazard of what we do. And he really said that it was our job to really work to heal our workforce as well, to ensure that our healthcare providers are actually receiving the support that they need after these events. And when we describe injuries, they can come in a variety of different ways. I mentioned, the surgical complication, right? This might be a traumatic injury. You experience or are exposed to some intense injury, something fairly horrific or potentially even a death of a patient. and you feel injured. We then talk a lot about grief injury, this idea that when we lose people, we begin to lose a part of oneself. And we've seen this happen even in the COVID pandemic, as more and more of our physicians had to deal with patient deaths that they weren't able to control. They began to experience a lot of this grief injury. And then fatigue injury is really this idea of accumulation of stress from all sources over time without sufficient rest and recovery. And I'll tell you, many of my medical colleagues describe this. They call it compassion fatigue. This idea that no matter how many times they can tell someone to get vaccinated and they don't, and they get sick, they're frustrated. They're so burnt out by telling them the same things over and over again and not being heard, that they actually feel like they're getting burnt out from that. And then finally, a moral injury. The idea that behaviors and witnessing of behaviors might violate moral values. And some of you may have actually heard of physician burnout called moral injury, that really people feel that what they see in their organizations is so egregious to them that it's creating moral injury for them. So these are all examples of different types of workplace stress that we really need to consider when we consider peer support. So we really wanted to talk a little bit about, when we started our program, we wanted to talk a lot about adverse events, because we found like that was an easy place to start our program and really focus our efforts on peer support. This study is from Waterman. This is an old study from 2007, looking at the impact of errors on physician life domains. And basically here in the red, you can see a serious error caused very significant distress for our providers. More than 60% felt anxiety about future errors, 50% decreased job confidence, as well as things like decreased job satisfaction and increased sleeplessness. You see, though, that even minor errors and near misses actually created that same sort of job-related stress, which is really very stressful to think about. You think about how many near misses we might see on a weekly or a monthly basis in our practices, and how much stress that might cause us, how we take that home, how we perseverate on it, and we can't sleep, and how over time, multiple areas of those injuries, if they go untalked about, actually can create much more burnout down the road. What I thought was really interesting from this 2007 study was the concern about harm to professional reputation. And these numbers were actually pretty low, but I would venture to guess, if the study was repeated now, in the times of Press Ganey surveys, Medallia surveys, and Yelp reviews, that I think many of us would actually be much more concerned about how one of these errors might impact our long-term professional reputation. And in this study, 90% of these physicians actually felt that their healthcare organizations did not support them in coping with error-related stress. And I found this astounding, that they really felt that their organizations were not equipped to help them cope and process some of these events that we see on a weekly or monthly basis. Many of you may have heard of the term second victim phenomenon. This was coined in the mid-2000s and was really this idea that a healthcare provider that was involved in an unanticipated adverse patient event or medical error actually also became traumatized by the event. We felt personally responsible for that patient outcome, and many of those providers actually feel that they failed their patient. They begin second-guessing their clinical skills and knowledge base. Now, when this was initially coined, I remember that there was a large pushback to this in the media as well as in professional journals. And the reason for this is that physicians really felt that they didn't want to be classified as victims. They didn't feel that that was an appropriate term. I don't agree. I think that the second victim phenomenon is absolutely imperative to discuss, because I think without it, that many physicians feel that they can't talk about it, that they're not allowed to have feelings about it, and that they should internalize those feelings. I also think from a patient perspective that it's important that they recognize that the physicians that they're working with are human. Now, I think this definitely came to light during the COVID pandemic, but I'd like to share a little story from my mother, actually. Right before the COVID pandemic, as I was starting this work at Northwestern, my mother called me up and said that her 80-year-old friend, who was having a revision knee surgery, ended up in the ICU due to significant blood loss during the surgery. And I said, oh my goodness, I hope she's doing okay. I hope everything's okay. And then the next thing my mother said, the mother of two physicians, She said to me, you know, that doctor must have made a mistake for her to end up in the ICU. And should they sue that doctor? And my mouth dropped to the floor. My mother is the most respectful person when it comes to physicians. I was astounded to see her take this work. And I said to her, and by the way, my mom's friend was diabetic and morbidly obese, so unfortunately had many risk factors for bleeding at the time of the revision. And my mother said, and I said to my mother, Mom, you've seen me come home after a surgical complication. I yell at my kids. I argue with my spouse. I can't sleep for a week. How do you think her doctor feels today? And my mother actually said, you know, I didn't think about that. You're right. They must feel as bad as you usually do if something goes wrong at work. And so I think bringing second victim phenomenon to the forefront in our discussions is so, so important. And so Scott really describes the second victim phenomenon in stages. This idea of that as physicians, we have to go through a recovery after we experience a complication, an adverse event, a distressful patient situation. The first one is chaos, right? An accident response. If I'm in the operating room and something goes untoward, I go into high-level thinking mode. I start barking at the anesthesiologist, the nurses, talk about what I need, what additional equipment I need. I need to get this bleeding stopped ASAP before something bad happens. While we're there, we're distracted. We're immersed in what we need to do. We need to manage this patient in crisis. But all of the time in our head, we're actually chastising ourselves for not being, for the accident actually happening. Then we get intrusive reflections. We start thinking about haunted reenactments of how this happens. And often this is while we're still closing up our patient. This is while we're still immediately leaving the room, while we have to go talk to the patient's family member about what just happened. We then go about trying to restore our personal integrity. And that's where I may walk out and talk to a colleague and say, oh, I've just had the worst day. Let me tell you what just happened in that case, and try to sort of figure out what my next steps are. Next, we endure the inquisition. That might be M&M on Friday morning. That might be an upcoming root cause analysis. That's certainly an everyday discussion with the family members and maybe other staff around the hospital about what happened during the case. And, you know, we always have the possibility that one of these cases might open us up for a future litigation. At some point, we as physicians often go about finally looking for emotional first aid. This might be a former colleague that you look to confide in. Some people might go to a therapist. Really, who is that safe person for you, if you think about it after this? And then finally, we move on, right? And when we move on, do we just survive? Do we thrive? Do we learn from that event? Or do we drop out? Do we say, forget it? This is not what we want to do anymore. So when we designed our peer support program, our goal was to take our peer support spaces that we usually routinely would go find some emotional first aid from much later in the process to much sooner, right after the case, when we begin to experience some of those intrusive reflections prior maybe even to the inquisition that we know we all have to go through after an adverse event. And that's when our intervention really occurs for peer support. This is actually a study done by Dr. Shapiro, one of my mentors in this space, who used to be at Brigham and Women's, as well as Dr. Hugh, who is one of our peer supporters at Northwestern. They did a study when Dr. Hugh was in residency, really looking at what doctors' needs were after having an emotional stressor like this. And you can see that, you know, the number one reason people didn't seek support was a lack of time. We're just too busy to take care of ourselves, right? That's no surprise to any of us who've come into work with horrible colds before, or after our kids have been up all night and then we go and do surgery for multiple hours. Another big area that was a concern was a lack of confidentiality. The fact that this would go outside of the spaces that it had to go and might impact our reputation and what others think about us. And another sort of area that was a really concern was a fear of documentation on the medical record. So when I did some of these surveys and tried to do a needs assessment of what I really felt like our department needed, these were the areas that I really focused on. And absolutely, my department really felt like all of these areas were the problem, the reason that they didn't go to employee assistance services. When we started our program at Northwestern, at that point, across the entire system, and that's like 19 hospitals, so many physicians, what we found is that EAP for physicians, attending physicians, had only been used 7 times in the previous year prior to COVID. And I'll show you some of our numbers that we sort of created from this peer support program. So before I talk about the way our program is set up, we really based it on some of the stress first aid modules that are out there for the military as well as for some of the firefighters. And though we don't use this exact model, this is actually how I train and teach our peer supporters to consider thinking about how they might provide first aid to one of our physicians. The first is really to check, to figure out where, assess, observe, and listen to what the other provider is saying and what they may need. Coordinate, make sure they get help and get referrals as needed. Cover, make sure that they're actually getting coverage for themselves if they need some space away for work. Make sure that they find time for relaxation, find time to refocus on themselves, get connection and support from others, and ensure that they're reaching out to colleagues to restore effectiveness, because we all know after a complication that we begin to second guess our own skills. And then finally, it's really restoring overall confidence that as you go back into the operating room, something like that will not happen again. So when we created the physician peer support model, I've given you a bunch of different sort of resources and different things to look at, but our ideal was to really say adverse events and distressful patient situations are occupational hazards for physicians, and that we really felt that physician peer support was a critical component to protect physicians from this hazard. Our commitment was to ensure that we had trained physician colleagues available for support. And our physicians are really trained in the peer support conversation, in stress first aid, as well as in empathy and active listening that we really bring from our coaching colleagues to better understand how to support our physicians during this coping process. We also work to begin to create a culture of trust between physicians to share experiences and allow us to better cope. And finally, to create confidential encounters. And this was actually performed with the help of our legal teams to ensure that all the conversations that our supporters were having with our physicians was completely confidential, and that the goal of them was not to debrief or do quality measures, but instead to help them cope. And this is actually how our referrals process moves forward. We first begin with the adverse event, the distressful patient situation, whatever it is that's being reported to us. And those referrals can come from a number of different sources. We've certainly had some doctors who self-referred to our program. We get a number of colleague referrals, doctors who see other docs struggling. We also get referrals from risk management. After a complication happens that risk management might be alerted to, they'll often reach out to us to ensure that the physician and other employees involved in the event can get support. We also now provide support around the peer review process, which historically at our institution has been fairly punitive. We're working on making it less punitive, and part of that is to ensure that we get some support structure around and supporting our docs through that process. And finally, we've teamed up with our legal teams to ensure that doctors going through a lawsuit also are paired with a peer mentor or peer coach who's maybe been through a lawsuit as well to help them understand the process. Any of these referrals actually come directly to me as the director of our P2P network, our peer support program at Northwestern Memorial. And I work to triage those to one of our trained peer supporters that I feel like can support that doctor best with that event. Our peer supporter then emails the physician who experienced the event. We decided not to page. We thought that it wouldn't be very nice for a nurse to read out in the operating room, Dr. So-and-so is calling you to see if you need any peer support. And then we work to really connect our physician to any additional resources. These conversations often are 1, 2, or 3 times to ensure that the doctor is continuing to cope well after some of that initial reaction to an event. And then if it seems as though they may need more resources, we pair very closely with our psychiatrists and ensure that we get them to therapists or psychiatrists in our institution or outside. The peer support conversation is very specific. We really like to use a very modular way to do this to ensure that our peer supporters feel comfortable with this conversation. And this is really adopted from Dr. Shapiro's work at the Brigham, where she really took a programmatic approach to what this peer support conversation looks like. The first outreach, as I mentioned, a nice opening with active listening and open-ended questioning. We give time for the doctors to really reflect on the event, to help them positively reframe what happens, potentially make sense of what happened, and really look for systems issues that may have contributed to the event, to really elicit how they're coping with that event, and then work on closing with resources and referrals as needed. And so since we've gone live, so I keep mentioning my department. Our program actually in our department went live about 6 months before this date in February 2020. And in that short period of time, we reached out to about 35 attending physicians and were able to provide support on a local level. Soon after we began that program, I was asked to create and run it at a hospital level. And given the large nature of our organization, that was quite the endeavor that took about 6 months to get started. Since we went live with our program in February 2020, we've now reached out to 160 attending physicians and have had peer support interactions either via email, in person, in Zoom, or by telephone call. We've also gotten some referrals from our resident physicians that might have been involved in cases and been able to forward those on to their appropriate residency programs. We actually then went on, you can see a map of our very many hospitals around the system. We went live with our system-wide expansion of the program just this past September 1st, 2021. And we've now trained over 59 peer supporters across our institution to really aid, to ensure that we're not making this process onerous for any one peer supporter to help their colleagues. We've also expanded our reach. You know, this program really started in distressful patient encounters and adverse events. We very quickly had to pivot in March of 2020 to discuss some of the work around COVID, and actually compassion fatigue. Our P2P recharge program was spearheaded by one of my colleagues, Dr. Priya Kunthaker, who's one of our neuro-oncologists. She really helped understand what compassion fatigue is and how COVID might be really impacting that. We also really worked during COVID to help our docs who were quarantined and away from their families during some of the exposure and risk that we had with our workplace injury when it came to that. We've also been working very closely, my colleague, Dr. Maggie Mueller, who is working on peer review and legal support ambassadors in our P2P program to really ensure our supporters are trained specifically to help cope with those types of situations. And finally, P2P Safe is our newest program that will be going live in the next few months, which is really looking at ensuring that doctors who experience difficult or challenging patient encounters, specifically associated with racist patient encounters, are getting the support they need through the avenues at our institution that are available. So what do you need to create a peer support program at your institution? Well, we really believe that leadership, training, confidentiality, and trust really go hand in hand to create the program that we have at Northwestern. So first and foremost, I think it's important to get buy-in at senior levels with leadership. You then really need to get local leadership, whether that's department chairs, division chiefs, vice chairs of faculty affairs, nursing champions, to really be the champions for the program and get the word out. Many of those people are actually our supporters, and many of them are also in sort of higher level leadership roles that have been able to bring this to the highest levels of our organization. I think it's very important that there is training for colleague support, because I truly believe that we need non-judgmental peer supporters to be able to do this work. We really need to train them to avoid minimizing or trying to solve the issue. As physicians, we are problem solvers. We want to make people feel better. That's our job every day. But actually, as a peer supporter, that's not our job. Our job is to help our colleagues find the best ways to cope for them. And then it's a way to really allow our colleagues to find personal forgiveness for the event that occurs so that they can really find that meaning in their work again and pull themselves out of that red zone and move back into the green. We also really believe that some of the work that we need to do from a confidential standpoint is to begin to create organizational change. So much of our organizations are based in quality and patient safety, as is absolutely necessary for our patient care standards. But we also need to recognize that our physicians need space to reflect, to talk, and be able to have these discussions in a confidential way. And that's what we've been able to promote at our institution. We also need to recognize that our physicians do feel emotional distress after these events. This is not a one-off. This is not the physician that's weak. Everybody feels this way. I often like to bring up at this point in my talk, I once had to peer support a physician who is a very difficult older male physician at my institution. I've worked with him in the operating room, and he always makes me feel about this big when we work together in the operating room. And I received a call that he needed peer support. And I thought it best as the director of the program that I reach out. And I immediately assumed that he would not want support based on my few interactions that I had with him in the operating room. And instead, I received a call almost immediately back after my email that said, yeah, I'd love to talk. I had no idea that people were paying attention, that they might have actually realized how much this bothered me. And I was blown away. And my own bias definitely came into role. I definitely had to pat it down and say, you know, even the physicians that I feel like tolerate this stuff, deal with it, or don't feel a lot of emotion after these events occur, do as well. And so this is a really important thing to recognize at an organizational level. Finally, I think in the long term, our goal with peer support is to begin to create culture change, move away from a culture of blame, really work to find what the systems issues that may have led to the complication that occurred, begin to train our physicians at a very young level that imperfection is okay, to err is human, and that is part of the work that we do. And then finally, really beginning to create trust in the organization. And really the only way to do that is, from my first few slides, is begin to build community in the organization. Now, when we talk about trust, this actually comes from some of the coaching work that I did in the last few years. Meister and Green describe trust in an equation. And because I'm a scientific and math person, this definitely appealed to my innermost self. But they define trust as really a firm belief in the character, strength, or truth of someone or something. And this equation really sort of, I think, very much tells the way anybody can begin to trust, whether it's an individual or an organization. The first is really credibility. Do you believe in what they're trying to do? Do you have like values? And do you see the actions that they do mirror those values? Reliability, that when something comes up, that you know they'll be there. And for my peer support program, it was very important to me that we have peer supporters reach out to every single person we get a referral to within 72 hours. And that is why I have such a large volume of peer supporters that I work with, to ensure that there's always somebody who's going to be available to be able to reach out. Finally, intimacy. And this seems like a strange one, right? What does that mean? Intimacy means that you're willing to share a part of yourself and become vulnerable in a peer support conversation. It means that you're not always going to be the problem solver, and you're not always going to know the answers to help your colleague, but that you are willing to be there and listen and be empathic and be by their side. And then all of those things are divided by self-orientation. So from my peer supporters, I tell them, the first thing I ask is, do you have the bandwidth this week to do this? Because if they themselves are experiencing a horrible week, they themselves are feeling burnt out or in the orange or red zone that week, they are not in a position to get out of their own head to support somebody else. And so I find it really, really important that we begin to identify that we are human and that not every day is a great day to do the work that we need to do, and that we need that time away. And really, that's the way that we work to create trust, and the way I teach trust in an equation format to my peer supporters as they begin to do these conversations. I have lots of animations there. I apologize. Okay. And so really, what are the barriers to peer support? And I tell you, it's the opposite of all these things. If you cannot get buy-in, either at a senior level or at local leadership, you are not going to be able to get a program off the ground. So it's very, very important. Now, I would say many of us have much data from our engagement metrics at our institutions stating that people are not engaged, people are burnt out. And so our leadership really should want to try to incorporate a program like this in. If your hospital can't ensure confidentiality for your doctors, if people are constantly being reported to someone senior or to a psychiatrist, they're going to begin to lose trust in the organization and in the system, and that is going to be detrimental to the program that you're trying to create. And then finally, burnout and engagement metrics are great to create and understand what the problem is. However, pushing the envelope on these metrics with a singular, insular program is almost never enough. And so what I often tell leadership is, I'm going to show you how many doctors we've helped, how many doctors we've worked on, how many doctors from each department we've been able to talk to try to get them through these events. But don't expect any changes in your burnout and engagement metrics, because there are so many other things at an organizational level that need to be fixed to begin to change those metrics. Don't expect it. That's not something I'm trying to do. And if that is what the program is going to be based on, the program is not even worth creating. Instead, we should really look at what people are burnt out about, ask them much more specific questions about what's burning them out. And then we may see that community and peer support is something that they're finding very positively, but that may not change the actual metric when it comes to burnout and engagement. So the key takeaways really for my talk, and then I'm really excited to take any questions anybody has, is that really a culture of wellness is built by collaboration between an organization and its people, and it must include caring for the individual, enhancing the workplace, and building community. We know that peer support is critical to enhancing all three of these arenas, whether it's through emotional support, coaching, or mentorship. And finally, the keys to a successful peer support program are leadership and training, confidentiality, and finally, trust. So thank you very much for your time, and I would love to take any questions that have come up through the chat.
Thank you so much, Dr. Chaudhary. That was fantastic. I've listened to you speak about this topic several times now, but each time I feel like I learned so much. So before we get to Q&A, I do want to just take a minute to highlight some of the other AMA Steps Forward resources. Please check them out in the resources widget of your console. These are some of the other Steps Forward toolkits that we have, and to add to this list should certainly be the one on stress first aid, which you referenced so much. That was also turned into an AMA Steps Forward toolkit that goes through each of those 7 C's that you highlighted, and it provides a practical step-by-step guide on kind of how to get started there. Okay, let's see, I think I can control this. Yes, okay. Whoops, did I skip one? Oh, no. Okay, apologies. All right, so another new program that we have is the Recognition of Participation Certificate, and if you participate in 3 or more of these Steps Forward activities, including webinars such as this one, boot camps, podcasts, telementoring sessions, and reading any of the toolkits that we have on our website, you can submit them to us and get a Recognition of Participation Certificate. And finally, if any questions come up at all that we're not able to answer today, please email us anytime. Okay, and now to the Q&A. All right, so our first question, this is a good one because we were chatting right before this call, and you were saying how before you hopped on today, you did a hysterectomy and then dialed into a national meeting, and then now we're doing this webinar. So how do you find time to build peer support and offer coaching without adding to your workday?
Yeah. You know, I started out definitely adding to my workday. I'll be perfectly honest, Dr. Zhang. But, you know, what I found was this really became a labor of love. This was something that I recognized that my colleagues felt they needed. And I was actually able to find leadership partners very early in this process. We actually we have an amazing program, which I know that there's been some AMA Step Forward work about, that's run by our Director of Physician Wellbeing, Dr. Gaurav Agarwal, which is our Scholars of Wellness program at Northwestern. And his idea was really to do grassroots programming at Northwestern to really begin to improve physician wellness. And I was actually able to build this program in our department as part of that Scholars of Wellness program, where I had a very, very teeny protected amount of time to do that. But since then, since we've been able to expand it to a more hospital level, the goal is really to incorporate this into people's work and to really give people time to get this done. Now, it's not a lot of time, I agree with you, but I really feel strongly that this is such an important part of what I do. And to be honest, brings me my meaning in work and probably prevents me from getting burnt out from doing too much.
Yeah, that's so true. And that goes back to Dr. Shanafelt's work, which, as you said, it's about finding what brings you meaning, not necessarily, getting paid more or cutting down the work per se, but it's finding the meaning in the work. Okay, next question. Let's see. Okay, so this was in reference to I think at one point you were saying that ensuring physicians have time for themselves, and in reference to, I guess, it's in particular, working parents. And do you know of any programs about and specifically if childcare is not provided at the site, or, any kind of solutions there that you know of?
Oh, goodness. We are definitely talking to another mom with this question for sure. I completely understand. Yeah, it's really difficult in general to find time for yourself. I have 3 children. Thank goodness this is during the day. Otherwise, they would have wandered in and out of my library here. But, what we know is that it's really, really important for us as physicians to really look to find that time. And I know it's very difficult, especially with young children, for our docs to really find this time. And, we actually have a physician moms group at Northwestern that talks a lot about this because all of us do feel very strongly about that. We don't have childcare at our site, though we do have many local childcares for emergency childcare that help out for our physicians. But what I've really told people is this is not necessarily time that you're going to take away from your family, but instead it's very important from a physician well-being standpoint to really go to your colleagues and go to your boss and say, this is the time I need away, because otherwise you can't do your job to the best of your ability. And I really, really advocate to my physicians to really sort of take that stand for themselves, to recognize what their needs are with their work and to be able to stand by those. Because if you don't, you're just going to keep spiraling downwards from the standpoint of burnout. That's sometimes really hard to do. I see so many people, people talk about it a lot on social media. What do I do? I don't feel heard. And I think it is important for us to recognize, like, it is okay for us to feel this way. We should be able to take time for ourselves, and being able to talk to your boss or your colleagues about that should be an acceptable thing in your workplace. And if it's not, that's a problem in the workplace.
Yeah, absolutely. Yes. I think that battery schematic you have is so helpful, because sometimes it's hard for us to articulate, what we're feeling. But if you're saying I'm in the red zone, I'm empty, I think that's a good place to start that. All leaders should be able to understand. All right. Next question is, who does the education and training for the peer supporters?
Yeah, so I was initially trained as a peer supporter by Dr. Jo Shapiro, who you've heard me mention a few times. She is an ENT surgeon at Mass General and has done some of the preeminent work on peer support around the country. She started a very large peer support program at Brigham and Women's many years ago and has published on this topic. And so we really had her come out and do some of our initial peer support training at our institution. From her work, as well as some of my work through my coaching certification, I've developed a training program. So I actually work to train all the peer supporters in our system. And so all the peer supporters have now been trained by me, and that includes about a 2-hour training session, as well as opportunities for simulated peer support interactions to really give them some comfort and experience with the process.
Excellent, thank you. Oh, this is a great question, because I asked it initially when I heard this for the first time. How do you encourage physicians to participate as a peer supporter? Are they incentivized?
That's a great question. And yes, I wish they were. They are not incentivized, but we are working on it. When we started this program, we really developed our peer support network with doctors who came either as referrals to us from other docs who felt that they were just empathic and supportive listeners. And then we really sort of ensure that they're not doing more than 5 to 7 peer support interactions over a year, because we feel like any more than that can become onerous for any one physician to do. But really what we've discovered is that our peer supporters who do this work are so excited to do it. They actually have been doing this work in their own departments, in their own institutions for a long, long time. That's why they were tapped as a potential peer supporter. And actually, they love the idea that now they have a framework to work around. They have training. They have a community of other peer supporters to talk to when things go wrong. They have a way to sort of send it up the chain and know what those additional resources are, because these are the docs that were doing this work. They're the empathic doctors who are always there and always listening. And so, unfortunately, unfortunately, Dr. Robitello, they're not incentivized. I wish they were, but I find that we never have a problem getting peer supporters. You know, after our first year, I did go to all the peer supporters and say, who needs to rotate off? Who needs the time back from this? And I had about 3 of my favorite peer supporters rotate off because they were working on other things. And they said, but we want the opportunity to come back in a year or 2. We just need some space and some time. And we were easily able to replace and recruit and train more positions.
Gotcha. Yeah, I think, and I know I worked with Joe Shapiro on one of our other peer support toolkit on Steps Forward, and I remember asking her this question, and she was saying how there was some data out there or some studies done that suggest just in this arena offering incentives or pay or whatnot, first of all, is not necessary, as you said, and also doesn't really improve outcomes, or it doesn't really help this process become more effective. It's really those people who are doing it just really are doing it out of the goodness of their hearts, and I love hearing that. All right, this will be the last question due to our time limits today. But do you facilitate workshops on peer support?
So I do. I don't do that in my role with Northwestern other than for our system, but I do actually help. I have helped other organizations set up peer support programs and do training for them. You might have seen on my disclosure side that I have my own little mini consulting. That's what I do through it. So I do actually do that, and would be happy if anyone wanted to reach out to talk about what that entails. Really just, because I have to take some time away from work. But absolutely, we have some great resources that we can share to help both set up a program as well as to get peer supporters trained.
Great. Thank you so much. So I know we didn't get to all the questions, but if there's anything else, again, please email us at the AMA Steps Forward email, and we can try to answer it ourselves or pass it on to Dr. Chaudhary to look at. But again, thank you, Dr. Chaudhary, so much for your time and wisdom and expertise. And this was such a great presentation. I can speak for all of us here that we have learned so much from you. Thank you again, and thank you all for joining in with us.